I have no disclosures regarding any financial relationships. Just a couple of quotes I always like. There's the Marcus Aurelius quote, "Everything we hear is opinion, not fact. Everything we see is perspective, not the truth." So that's relevant. And also a nice quote from John Barth's story of, "Everyone is necessarily the hero of his own life story." That's what my wife always reminds me whenever I talk about somebody saying something. She says, well, everybody has to be the hero of their own story. The background, we'll talk a little bit about the background, about the tubal model, some issues of origin and trajectory, tumor genetics and trajectory, and primary and secondary prevention. For the background of ovarian cancer, it's a pretty straightforward history of a disease which has improved somewhat in survival, primarily due to the onset of, or the development of certain chemotherapeutics, as well as just better supportive care. And the 10-year survival has improved slightly to about 20% now. If you look at long-term survival, it hasn't changed a great deal, but it has shifted, the curve has shifted to the right, at least in the short term. So as you all know, people are living longer now, at least in the short term, and the long-term survival still remains at around 20%. And for long-term survivors, I always thought it was fascinating to read about this from these articles about people who do live a long time with high-grade serous cancer, often are high stage at the original diagnosis. They often recur after initial treatment, but they're, as in talking with Dr. Swisher, they're usually platinum sensitive and continue to do well. But even some of them, failed after less than 12 months, but they still lived a long time. So it's an interesting disease in terms of trying to understand what it is that keeps you alive other than platinum sensitivity. Plus, elevated mutation burden, BRCA-ness, and immune response also influence how long you live. This is a quote from J.D. Woodruff back in 1979, which says pretty much what we would say right now, that it's very difficult to manage this disease, and that our basic effort should be trying to figure out where it came from, because that influences that may influence how we manage it. High-grade serous carcinoma is what we're talking about, of course, which is about probably 75% of all the cancers. If you look through a lot of the databases, you may not see the word serous, but usually you'll see poorly differentiated or high-grade, and most of these now fall into the serous carcinoma category. It's a broad category. It's not entirely homogeneous, but it does basically cover those tumors that have p53 mutations. The ovarian model, as you know, was the one that was usually followed in the past. The assumption that these tumors started near the ovarian surface because that's where we found them. And the ovarian perspective, even back in the 1990s, was the one that dominated because that's what we thought. We thought they started in the ovary, and that's what we thought had to be removed to prevent disease from occurring. Debbie Bell and Bob Scully did the really nice study, interesting study, where they went into his consultation files and found only 14 cases of what they called early ovarian cancer. 14 cases. And they concluded by saying they didn't really think that this was a disease that could be easily managed by screening because so few of them presented at an early stage. This image you see on the right was one very similar to what we saw when I first got to the Brigham in 1990. And it was a patient who had had a small focus of cancer in her ovary that was missed at the prophylactic, and she recurred several years later. And we then pulled the slide and found that ovarian surface tumor, and we had concluded that that's probably where it started. It must have started on the ovarian surface. But the tubal story really began to evolve around then also with the effort to remove the tubes and ovaries of women who were at high risk, even before they discovered BRCA1 by King and her colleagues. But that led to really widespread testing. And then beginning around 2000 was a kind of a slow cascade, if you will, of understanding about the fallopian tube. And many individuals began to identify small numbers of cases of BRCA patients who had tubal cancers. And in 2005, we decided just to create a protocol that would figure out maybe where they came from, because I never believed they started in the tube. I told Terry Cogan, I said, I don't see anything in my tubal ligations. That doesn't make any sense to me, but we decided to do this protocol and look at the distal tube. And soon after, we began to appreciate that was the site, as well as Cass et al. published a paper about the same time observing that the fimbria was where they found their tumors. We then did the next thing, which was look at the sporadic population for these early cancers, and then we began to look for early parts of the carcinogenic spectrum. And then not long after that, other individuals began looking at prophylactic salpingectomy from several institutions, which includes this one, as well as Sloan Kettering, and also in Houston with MD Anderson. And then the opportunistic salpingectomy story started to come along around 2013 with Diane Miller in British Columbia. And now we have the recommendations, and we have the more recent studies by Steenbeek, who's shown that the recurrence rates of primary peritoneal carcinoma after discovering early cancers of the tube in the BRCA population are much higher than we expected once you follow the patients out, as well as Hanley studies showing that in a relatively small number of 25,000 each in each arm of their study, they found that they did find a small number of serous cancers, but only in the patients who did not get prophylactic surgery, or let's say opportunistic salpingectomy. When we introduced the CPIN protocol, it was pretty straightforward. We just amputated the fimbria and then cut them lengthwise. And this looks a lot better than it does in reality. Obviously, when you really look at the sections, they can look maybe not quite so pristine, but that was the effort. In our first study, we did that protocol starting in January of 2005. In about a month or 6 weeks, we had a bunch of cases, which was kind of neat, because it meant that we were probably finding something. The case you see at the very top here, this patient had kind of an endometrioid carcinoma in her fallopian tube. I forgot about her until very recently. Someone wanted me to pull the case because she's still alive 20 years later as a BRCA patient, and she was being treated for either breast cancer or for a recurrence. The case down here on the lower left, which is a STIC, that patient had a positive peritoneal cytology, but they couldn't find anything. So I think they did a couple of levels of the tube and didn't find anything, and we put her in the study and cut more levels and finally found the cancer. So it's not always obvious when you first look in the fallopian tube. What did the CPIN protocol provide? I think the good thing about it was it immediately kind of shifted us to look at the fallopian tube, but what was really, I think, the most useful thing was you didn't have to believe anybody, you just had to use the protocol, because most of us don't believe anybody. I think when Peake came through in 2001, having seen some dysplasias of the tube, he didn't get much attention because there wasn't a whole lot of information. But once people could apply the protocol, then they saw it and they said, yep, looks like it's something there in the tube. And it's also a device to look for potential risk of recurrence, because you can then carefully surveillance the tube for any precursors that might come back. And here's just a typical example, actually not as common as you might expect, a nice serous tubal intraepithelial carcinoma with a focus of invasion in the fallopian tube. And that is actually a minority of the kind of cases we see. This is interesting. This is a case we saw early on. A woman had a very small ovarian, and again, an endometrioid type carcinoma, a BRCA patient on the ovarian surface. Tubes looked normal, but we cut the tubes deeper and we found a little early endometrioid STIC, if you will, in the tube. So basically, if you added up all these studies, roughly over 90% of patients who came in who were healthy, who were BRCA, who had a cancer, who when they did have any kind of cancer, early cancer, it was found in the distal tube, usually in the form of a serous tubal intraepithelial carcinoma. And so we went and asked the next question, which was how likely are we going to find this in the sporadic population? So we started looking at cancers in women who were not necessarily BRCA mutated, and discovered again these early cancers in the tube in about 40% of cases. And that was the average. It was kind of interesting. It wasn't 94%, it was 40%. And so I said, well, maybe it's because they're not BRCA. Maybe the BRCAs all have 90%. Maybe we'll find it in those cases. But symptomatic women with high-grade serous cancer, on average, about 40% of them were found to have a STIC of some sort. And the next thing we did was to look for earlier lesions. And we did that probably because we were paranoid. We were staining tubes all the time, afraid we'd miss something, and suddenly we were seeing essentially normal-looking epithelium with clonal p53 mutations. And I remember looking at this for the first time with Frank McKeon, who was the guy that cloned p63. We were sitting there and I said, Frank, that looks important. And he says, no shit. That was his response. But we kind of laughed about that afterwards. But, you know, it was interesting because it gave us kind of another part of the spectrum that you might expect to occur. And typically, we began to assume that you had a progressive spectrum like you do in the cervix, you know, CIN 1, 2, and 3, cancer, maybe this lesion followed by STIC, followed by cancer. The p53 signatures, which were really just mutations in relatively normal epithelium, lacked a couple things. They weren't atypical. They had a low proliferative index, and they didn't express cyclin E or Stathman or P16, all these markers that you typically see in cancer. So they definitely were a clonal event that didn't have a lot of impact on, at least were not assumed to be high risk. And this sort of brought this concept of early serous proliferations. You know, on one end you've got lesions that are not very impressive. On the other, in the middle, you've got things you're not sure about, called stills of uncertain significance, intraepithelial lesions. And you had at the other end things that you could clearly say were intramucosal carcinomas. And of course, there are all these pieces of evidence sort of conspired to point an arrow toward the fallopian tube as the source. There were other clonal events also that you could find that we discovered, which were basically a parallel universe. You know, they had loss of PAX2, they were discrete, but they didn't have a mutation in p53. We call them secretory outgrowths or stem cell outgrowths. The type 1 was one that looked sort of almost like normal epithelium, but it was clonal. The other one was one that looked very endometrioid. We called that a type 2 or endometrioid scout, and they had consistent beta-catenin mutations, which was kind of neat. So now we had this idea of, you know, where you had this sequence of events producing a tubal sequence of neoplasia going from totally bland-looking mutation followed by the development of an intraepithelial carcinoma that could then either invade or then disseminate into the peritoneal cavity. And this really kind of encouraged the so-called sequential model. This is one of our images suggesting you're going from here to here to here to here to cancer. Ronnie Drapkin's was very similar. Here's one that's quite elaborate and brought in a number of different factors. And Brown and Palmer constructed a timeline where you had genotoxic injury, STIC, which made perfect sense, some kind of latent period, and then you would develop early and late cancer. But we were kind of caught up in this sort of things had to go sequentially, and a lot of this was informed, I think, by the BRCA asymptomatic patients where you saw this nice spectrum, and you figure that's what happens all the time. But there were things we had problems with, and the first one was the trajectory issue. For example, we finally got a hold of a bunch of BRCA patients who had cancer, and in contrast to the asymptomatic population where STICs were found like 90% of the time, we only found STICs in about 33%. And so we're scratching our heads saying, well, what's going on? Where are the rest of them that we should be seeing in the BRCA patients? At the same time, I think, and this may be biased by what we looked at, but in contrast to cervical cancer, where you have a nice peak of precancer and a peak of cancer that are separate in time, as you expect, the STICs and the cancers kind of overlap pretty well in those patients in terms of age. So you didn't really have this nice notion of STIC that sat there for a long time and then invaded and became a cancer. You got this feeling there was something more complicated, and you just couldn't explain it all by just a single precursor that took its time getting to cancer. And we also found the STIC was pretty uncommon in the general population, somewhere around 1 in 1,000 women. It was interesting when we found STICs at the Brigham, they often associated with endometrioid lesions or endometrioid cancers. They were just a separate entity that was associated with a condition that really had a different pathogenesis. We thought that was interesting, and others have found the same thing. There's something about women that are prone to getting, let's say, endometrial cancer, that they may be a greater risk for developing a serous carcinogenic sequence. It may not be that complicated. It may be immune. It could also be hormones. It could be a number of reasons, but they don't really cause each other, but they do sometimes segregate together. Another thing that bothered us was that certain cancers didn't seem to have many STICs at all, and particularly the ones that looked endometrioid-like. They had p53 mutations, but they looked like endometrioid. And here's one such lesion, the solid carcinoma, has a lesion next to it, which is some kind of p53 thing, but then the cancer sort of develops instantaneously next to it, suggesting that the trajectory to cancer didn't always include a gradual thing where you could actually pinpoint the transitions. And so we suggested in Brooke Howitt's paper that in addition to the Brown and Palmer thing, you might also have a somewhat different trajectory with an alternate precursor, or maybe a more rapidly developing cancer, maybe a shorter occult period. Maybe you had different morphologies, such as the solid endometrioid or transitional carcinomas may have a somewhat different trajectory in how long if they had any kind of STIC. And so a while back, I decided for fun just to take a look at 387, the reports on 387 serous cancers that we had. And I divided them into those that had an obvious STIC, those that had nothing in the tube that you could identify that looked like a significant precancer, and the ones in between where you really couldn't tell what was going on because there's so much cancer. So you had a little less than 20% on one end, you had but 20% on the other, and 60-some% in the middle. And so you could argue on this side that yes, you have a STIC, so you could say that it may have initiated as a STIC with some variable trajectory, which would pretty much make sense. Question was, what do you do with the other two categories? The far right category is, of course, your primary peritoneal carcinomas. They have widespread involvement, but the tumor in the tubes and ovaries is really just serosal, and you don't really know where the tumor started. One potential explanation is primary transformation of endosalpingiosis or cortical inclusion cysts, and this would be a situation where you could argue that benign Mullerian cysts undergo malignant transformation. Another possibility is that you just have an occult malignancy in the tube and the cells are transported to the peritoneum. And truly, about 50% of primary peritoneal carcinomas, you can find sometimes a STIC in the tube. But we're not really talking about that so much as the ones that don't have any STIC at all. And then you may have pre-malignant cells that, let's say, were not STIC, but somehow got into the peritoneal cavity and then later went malignant. And that might explain why you're looking at a cancer in the pelvis, but that you'd like to attribute to the tube, but you cannot find a STIC. There were the cortical inclusion theories, and they were able, these investigators were able to actually find genetic abnormalities in the lining cells of the ovary, but they didn't find p53 mutations very commonly. And when they did find cases like this, they were almost like reportable. They were so rare. We and Barakat et al. Probably looked at 800 or so sections of ovaries from patients with BRCA mutations. I think we found one possible p53 mutation in one case. In other words, you just didn't find these p53 mutations very commonly. Whereas if you take 100 women, who are, let's say, middle-aged, and you look in their fallopian tubes, half of them have p53 mutations. They have little stretches. They may not be doing anything, but they're there. So they're quite common, and the BRCAs have that as well as and perhaps more. So the other question then was, are we getting exfoliation of cells from STICs or stills or even lesser lesions that might be escaping and then progressing to carcinoma once they got out of the tube? And that would explain why we were looking at what we were looking at. And these are what we called ESPs, or early serous proliferations. And so you had this range of lesions. You tried to exclude these, but could these lesser lesions perhaps be involved in this, at least in some cases? So Arinda Soon, who was a fellow with us, took 32 cases of high-grade serous cancer in which nothing was found in the tubes. And then she serially sectioned the fallopian tubes and looking for something. And in 3 cases, she was able to exclude, I'll move on. In 3 cases, she found a high-grade, a serous tubal intraepithelial carcinoma and took out 10%. Now, the remainder cases, those cases, she found some ESPs, if you will, that stained positive for p53. and then did some sequencing on them and found in some of them evidence of a mutation that was identical to the cancer, suggesting that something a little less than a STIC could be responsible for the development of these lesions. So that's the question. Could a shared p53 mutation between an ESP and a high-grade cancer indicate that maybe cells got away from the tube before they became malignant and they became malignant later in the peritoneal cavity? And these are some examples, not of cases that we've sequenced. There's cases I just saw recently that I think are just kind of interesting to show. Here's an ovarian ovary with a small early cancer. And you can see in the adjacent tube a rather large still, if you will, serous tubal intraepithelial lesion with some degree of Ki67 staining. And I don't know what the sequencing was of these, just to show you that we see this quite often. Here's another example where you've got a serous cancer, then you've got this somewhat atypical lesion in the fallopian tube without any evidence of STIC. Here's another example where you have a surface lesion of the ovary. It's null for its p53 mutation, meaning both alleles that encode the protein that you're looking for are lost. Then you look in the tube next to it, and you can see again a still, if you will, that's also p53 null. This is a case we had, I think I showed it this morning to the residents. We had this back in 2005. It was another still. It was rather large, but didn't look like, we didn't think it was enough to call a STIC. Higher power, you can see it's somewhat stratified or pseudostratified, but it was quite cohesive, had a very low proliferative index, and she developed primary peritoneal high-grade serous cancer about 10 years later. I just looked her up because I was looking up some of our stills to see what happened. The problem we have is most of these patients don't come back. You see them and they may go off some other parts of the world, so you didn't really have a record of what happened to them. It'd be nice to know how many of them really developed something. It'd be an interesting study to see how many in-between lesions that you really can't call STIC actually turn up with a cancer later on, because that would be very important. But this case, I just happened to look it up and said, holy moly, she had a primary peritoneal 10 years later. And another interesting thing about this whole issue of where things come from is this nice study done by Yiming Shi's group, where they tried to figure out some sort of phylogenetic tree to link up precursors to cancer. And if you look at this part of the tree, you start off with your ground state, if you will, and you have two arms, and both these arms are mutations which are different, so that your signature and your cancer obviously are not related to one another. They both come off, but they're not together. Here you have a tree that has a single mutation that in the end has your STIC and your cancer very close together, suggesting a very close relationship and a close timeline. You might not know for sure how it happened, but that would fit most notions about how these tumors develop. But then you had these cases where you had the truncal mutation in p53, and then phylogenetically you have this split, and your STICs are over here and your cancer is over here, suggesting that they're not as closely related. And that's curious, you see. And you see another one over here. You've got a STIC here, you've got a STIC here, you've got a high-grade serous cancer. All of these have the same mutation, but they've acquired other mutations along the way, and you're trying to figure out what happened when. We did a much less sophisticated study. We looked at just 3 cases of concurrent still STICs in both tubes. If you got a STIC in each tube, then one of them has to be the primary. Both can't be, right? If they have the same mutation. And in one case, they shared the mutation. Another case, they did not. Another case, you had a STIC on one side that had 2 mutations. It was shared by 2 mutations on the opposite side with a still and a STIC. But those 2 lesions also had another mutation. So they weren't exactly, you didn't know exactly how these things evolved. So this just underscores how complicated the relationship might actually be in many cases between the malignancy and the precursors that we're trying to define as the origin. So, based upon what I've shown here, I think there is some kind of precursor escape argument or earlier transitions to high-grade serous cancer that would explain the ones where you don't really have a STIC in the fallopian tube. So you're left with the extensive, tubal ovarian high-grade serous cancer without a STIC. And so, how do you explain these lesions? Well, we're talking about something, I say spontaneous from 0 to 60. I'm not saying that you develop the tumor in one day, but that the tumor develops much more rapidly than we think with these so-called long intervals. For one thing, the only consistent mutation in high-grade serous cancer is TP53, so that's the only thing you can guarantee is going to be found. Other than STICs, which are found incidentally and occasional cases of STIC with focal invasion, we don't really see much in between the benign TP53 mutation and the cancer. Often we don't see much at all. Other genetic events are extremely common that could occur over a short time interval, and these are all published, such as polyploidy chromothripsis, which is shattering of the genome, and segmental copy number changes, which might support the notion that intratubal or intraperitoneal high-grade cancer can develop quickly, bypassing a stepwise process. I had a conversation with Jingsong Liu, who was at MD Anderson about 10 years ago, and he was talking about polypoid or multinucleated giant cells as being cancer stem cells. And I always had difficulty getting my head around cancer stem cells. And I listened to him, and I didn't really understand, but he was really talking about cells that he felt had stem-like capabilities, and in culture they persisted, and they probably represented the underpinning or the basis for high-grade serous carcinoma. Long-term survival, chemo resistance, but the key was polypoid or multinucleated cells, indicating that something could happen to create a cell like that did not take a long stepwise process. This could happen very suddenly. And then there were a number of studies looking at polyploidy, some from this institution, that suggested it was an early event. And this is a study of a single case from McGill, where they had a patient who had a small STIC with early invasion, and then I think 12 years later she came back with cancer in the pelvis. And the only difference between that lesion that was in the tube and a recurrent cancer was the recurrent cancer was tetraploid. And again, tetraploidy would suggest something happened quickly, or relatively quickly, to make that transition. Chromothripsis is something else that's quite common in these cancers, and this is basically defined as clustered chromosomal rearrangements, a cluster over a reasonably large area, like it's 10 segments as defined by the microarray, meaning you don't just have a stepwise edge, you have a lot of things happen all at once in the chromosome and it gets rearranged. I don't think one can argue that necessarily targets a specific part of the genome, but clearly it indicates that something quickly happens to create genomic instability. And it's very common in tumors with TP53 mutations. This is just to illustrate the frequency in ovarian cancer, which is about 60%. This is from a study that we're going to present at the USCAP meeting that Ju Yoon, our fellow, did. He did a couple things. Number one is we did an oncoscan of 17 cases of high-grade serous carcinoma, looking for evidence of chromothripsis, and we found it in about 63% of cases. He also went to the TCGA database and found the same, showing that there's a tremendous number of tremendous number of things happening to the genome in these tumors, and it is basically unrelated to stage. Even relatively early stage cancers have a lot of this, as well as late stage. So it's not something that's accumulated over time, and that these high-grade serous cancers that you're seeing appear before you probably develop through a number of genomic. You can also see there's also tetraploid and triploidy in these cases. And so it's kind of, here's an example of what might be happening. Here you have a P53 signature, or a very, very minimally atypical epithelium, and then suddenly you've got this mass in the fallopian tube that develops without seeing an intervening STIC, suggesting, and you see this not infrequently, suggesting that something is going on to fuel this transition that's not going to fit our typical perception of going from this to STIC to invasion to cancer, that you're bypassing that. And going back to our other case we talked about, where you have a little bit of atypia in the tube, next thing you know, you've got a large mass right next to it, and you don't really see what we usually expect to see when we're looking at cervical cancer, or something where you can actually see the early invasion. So, I think that one can make the argument that the majority of cases that we're looking at have an abrupt transition to cancer. Abrupt in the sense that it doesn't go through many stages. It may take several months or whatever to become obvious, but nonetheless, I don't think you're going to see what you typically see in the prophylactic cases. So I think of it as kind of an iceberg thing. At the tip of the iceberg is what we saw first, which was non-metastatic STICs, slowly evolving, more likely to be asymptomatic. And you find the STIC, and then they come back with cancer, and then you create this sequential pathway to cancer. But what we're really seeing most of the time are the patients who come in who are symptomatic, who have metastatic high-grade serous carcinoma that probably evolved more rapidly. Of course, as you know, this is another nail in the coffin for classic ovarian cancer screening because of the speed at which it occurs, also aided by the observations from the follow-up studies. And we now, of course, have the recommendation that prophylactic salpingectomy might offer us an opportunity to prevent ovarian cancer. In terms of preventing extra-uterine carcinoma, I think most cancers evolve over a relatively short time frame from pathways that do not involve STICs or stills with a long lag phase. And salpingectomy, therefore, is particularly time sensitive. So, I think waiting 6 months, or waiting a year could be pivotal in these cases if the tumors develop quickly. In my family, we had a member of our family that, she wasn't BRCA, but she was perfectly happy, healthy in July, and then by October she had symptoms, and she had a grapefruit-sized mass in her abdomen by Christmas. And I think that sort of speaks probably to a relatively rapid evolution. And progression of documented isolated lesions is usually slow, and you document them through, risk reduction surgery. You find these healthy patients. Once discovered, prevention becomes a function of destroying or recovering as many cells that got away into the pelvis. So this is their scenario. Your slow scenario, you go through a stepwise pathway, which I think can happen in some cases. You've got the fast scenario where you really jump from precursor to something that can be metastatic. And then you have the delayed pathway where you may find them when they have a STIC or a localized lesion. Most of those patients won't develop cancer, but some will because the cells have escaped into the peritoneal cavity. And this is just a way of looking at how your preventive methods work. I think if it's happening quickly, then if you do salpingectomy when there's nothing more than a signature, and you prove that by looking at the fallopian tubes carefully, you reduce the risk of developing cancer to be under 1% based upon the studies that have been shown. In the second scenario, if you do salpingectomy and you find a STIC that's not really metastatic yet, or let's say fully aggressive, you have, most of the patients will probably not get cancer, but a significant percentage will. And then finally, your scenario 3, of course, is you did develop it, the cells are loose. How do you remove these cells from the peritoneal cavity to reduce the risk? And would that even be feasible? So the question is, you're really looking now into the peritoneal cavity of these few women you see that actually have a STIC but don't have cancer. And you assume that there are cells floating around the peritoneal cavity that are not cancerous but could become cancerous, and maybe only one cell would be the one to go, right? One cell would undergo a catastrophic event. That's totally different from a woman who's got an abdomen full of cells that are malignant. These are pre-malignant cells. You might say, can you give chemotherapy to kind of, can you give her a couple doses of cisplatin? And the problem with that is, as we've learned from a lot of neoadjuvant studies, when you look at the fallopian tubes of patients who've been treated with neoadjuvant, usually they have very healthy looking STICs. Because the STICs are not turning over like the cancer, right? And therefore they may be more difficult. Yes?
Yeah, I just have a really quick question as you're on this topic. Have you looked at any molecular markers that are predicting whether STICs will go fast or go slow? Because it seems like that would be super helpful to know.
Yeah, that's a good question, and I don't have the answer. I think some studies that have been done do show that they're different from the cancers. Obviously, finding the STIC that's a cancer becomes a problem because you're not sure it's a STIC anymore. I mean, it may be more of a pathologic, our inability as pathologists to actually separate those out. But it's a good question. And in terms of rapid development versus slow development. So again, this is just you're looking at the peritoneum, and again, you're looking for that cell theoretically, and is it possible to capture those cells in some way, and therefore, prevent that risk? Can you wash? Can you do? You can talk to somebody who's a surgeon about washing the peritoneal cavity and removing all the cells. They're going to look at you like you're crazy, right? And I understand that, but I'm not naive. I understand the problem, but that's just the point. So what to do in the future? What factors do we have that link these pathways in the fallopian tube? What triggers the sudden molecular events leading to high-grade cancer? Where do these escape precursors go? Do they really go in the fluid? Do they go to the omentum? Would you ever do an omentectomy of a patient who you find a STIC? Would that prevent it? Who knows? If they're suspended in the peritoneal fluid, can they be captured? So these are difficult questions, but it's certainly, I think the first step is to find out what's out there, what's getting away, and try to selectively remove those cells, or at least find them and examine them in patients who do have precursor lesions. Just a couple final things. It is interesting how you can have a p53 positive cancer, and next door, if you do a beta-catenin stain, see beta-catenin mutated epithelium. And we've seen several cases like this. Again, not saying that the two entities are related directly, but there may be underpinnings in the fallopian tube that maybe support or increase the risk of these types of lesions. And finally, just to close, many patients have lots and lots of precursors because they have a p53 mutation, and I suspect it only takes a little bit of DNA damage to knock out the other allele. Therefore, you'll see lots of signatures. This patient had very few signatures when her left tube was taken out. When they took her right tube out 9 years later, there were a lot of them in there. So it implies that over time she accumulated more and more mutations. But these women, I'm not sure they live long enough, but they definitely don't get high-grade serous carcinoma. So you can point to p53 and say that's perhaps important, but it's not the whole story, obviously, and underscores the complexity of this business. Finally, just to acknowledge all the people that we've worked with and who've been a tremendous help in trying to address this. And with that, I think we made time. So that's that. Thanks.
So in looking at the precursor escape idea, it seems like if that was common, you'd see more patients who get primary peritoneal cancer after oophorectomy. And when we looked at our primary peritoneal cancer patients that were classified that way, it was only like 10% that really had a prior bilateral esophageal oophorectomy. And so, but I'm wondering if you even took that small subset of patients that had it, like if you looked at their age of, have you looked at their age of oophorectomy to kind of define, like, if that, if that influences their subsequent risk?
Yeah, so the issue, are we talking about BRCA patients then? Or just
no, I'm actually talking about anybody, like the idea that you could have a precursor, like seed, but of course you'd see it more in a mutation carrier just because the risk would be high.
Yeah, I think it's a good question. You could ask what the timing was in terms of whether they're at greater risk of developing primary peritoneal. I guess the question, as you know, and we discussed, what was going on in the tubes in the first place? Did they? I suspect that. I know in our study of primary peritoneal, about half of them did have something significant in the fallopian tube. That was probably the source of the tumor. And then you have another subset that you don't really find anything. And I don't know. I think it's probably uncommon. I think because most people, the average, if you only have a STIC in 1 in 1,000 people, you'll maybe have a few other lesions in that population that could theoretically shed cells that might become malignant. But my guess is, in most cases, they don't. So I think it would explain why you don't see much in the general population. As far as the age and the time course, I don't know. It's a good question. I don't know whether you're more likely to get it, later versus earlier. I know people worry about taking the tubes out too late for fear that something's already developed and spread, which I think is a good argument, is a concern. But I don't know how long it'll take to get that data. That's a good question. I don't really know the answer. Larry?
Question in the chat. I'm trying to open it. Take a look. Maybe someone else has a chat.
There's a chat up here.
Oh, there are two questions.
Let me get my glasses.
So Rosanna Reese says, do you think the tissue microenvironment might play a role in terms of extra self?
ESP is the early serous proliferations. Well, I think I know for certain that we've seen cases that had really impressive inflammatory responses to the epithelium. If you're referring to the actual fallopian tube itself, and I think clearly it might. Even these so-called scouts that are not p53 related do have immune responses. You do see immune cells near them. So I think it probably does play a role. And I've seen cases where you had long-standing lesions in the tube with an impressive immune response, and which obviously must have influenced the trajectory of the disease. But they're pretty uncommon. Most of the time, you don't see a lot of inflammatory changes.
I have a question also. As one of the sites where there was an ovarian spore for a while, I was aware of some of my colleagues' efforts to find a set of serum markers, and that turned out to be pretty non-productive to my knowledge. Is that still the state of serum?
Yeah, I think the serum markers, the classic serum markers, you can find things like CA125, but I don't, or AG4, HE4, I think, but I don't know if they've ever progressed to be very successful. A lot of these markers do work when you take a patient who's got overt cancer, and you can draw serum markers and find a number of different things. You can look for, a number like microRNAs or whatever. But I think when it comes to actually predicting, it's more difficult. And we went through all this with the Pap smears, or looking at Pap smears, looking at samples of endometrial tissue and finding the mutations that you're looking for in the cancer. The problem is, there's a lot of mutations in the GYN tract, and you'll encounter them. So it's hard they're not very specific. Maybe sensitive, but not specific. Yeah. No one wants to take the uterus out of somebody who's got a p53 mutation in there, unless they can be more specific. Some people have used additional markers, multiple markers, and they do look better, but I'm not sure that they've been able to prove that they offer any advantage.
Are there any other questions?
I have a question. Is there any prudence, or is it possible, do you think, that, like in that fast pathway where it's progressing from these early serous to seemingly directly to high-grade serous, is it possible that these are actually progressing from STICs that have just been obliterated?
Yeah. The argument is they just STICs that got overgrown, and I think that's a legitimate argument. Given how few STICs are out there in the population in general, it's harder to make that argument. We always find about 10 or 15 or 20 times more SYN3s than we find cancers. We're talking about STICs being almost not as common as the cancer, or about the same, which makes it more difficult to argue that you had that many STICs that were overgrown. It's possible, and it's possible there were STICs, but whatever was the trajectory of that disease was different than when you discover a STIC with a small focus of invasion next to it. But as regarding the comment about actually doing genetics on these lesions, I think it would be very useful, because then you might understand the difference between a fast and a slow STIC in a properly selected group.
And I think from a clinical standpoint, you would follow that patient so much differently. You might be seeing them every 3 months versus, I think that it could have a lot of important clinical implications. So I would encourage you guys to do that, because I think it's important. It's an important clinical question.
Well, you guys have great sequencers here. I know that. What we have is politics where I am. No, never mind.
Thank you, Dr. Strong.
Thank you all. Thank you.